All right, this is now 1:38. All right, assalamu alaikum, everybody. Ramadan Mubarak to all of you. I'm sorry for, postponing it another half an hour, but I was in the middle of a meeting and I could not finish earlier. Do you guys hear me?
Yes, doctor.
Okay, good. All right, so I believe we have gone actually over the PBC, the primary biliary cirrhosis. It's a disease with autoimmune, etiology at its base as its basis. And I mentioned to you what is the lesion of interest really. It's going to be a sheet or sheets actually of plasmacytes and lymphocytes, mostly lymphocytes, and also a granulomatous inflammation that could be seen. And you can see that in this picture right here. So this is what looks like almost an organizing follicle. And there is, this sea of lymphocytes and also, a few plasma cells here and there. In addition to this, if you go on high power, you will start to see that some of those cells that make up this inflammatory infiltrate have what you call epithelioid appearance. These are activated macrophages, that you see with granulomas, with the granulomatous formation. And it is, acaciating, meaning there is no caseation, there is no necrosis that is destroying this poor bile duct right here. You can see that the bile duct is no more, the wall has opened up and the bile ducts will simply, disappear in a little bit. The inflammatory cells will destroy it completely, okay? All right, so that's PBC, okay? Now, even more interesting entity is going to be the primary sclerosing cholangitis, another actually biliary cirrhosis disorder. Okay, so the end result of this is going to be cirrhosis of a biliary origin, of a bile, leak or a bile retrograde flow origin. Again, the same exact thing that you see with primary biliary cirrhosis, that is, autoimmune in nature, but different kind of antibodies, different kinds of, characteristic lesion. All right. Now, also, this entity has what you call a very peculiar association with ulcerative colitis, a very important thing to keep in mind. Okay. So PSC and ulcerative colitis and also colon carcinoma. Remember that. Now, the PSC itself, the primary sclerosing cholangitis itself, may give rise to cholangiocarcinoma in the liver. So two types of carcinoma that may arise from this entity. One of them is the cholangiocarcinoma, by virtue of the chronic inflammation that's happening in the liver as a result of the robust, autoimmune inflammatory activity that goes on, and it's a very, very powerful kind of injury, to the liver. And in addition to this, the colon carcinoma that could be, that could emanate from the ulcerative colitis that is highly associated with this entity. Now, the characteristic lesion is a very peculiar lesion. It's called what you call actually onion skin fibrosis. So what happens actually is that the biliary tree, the bile ducts, intra and extra hepatic bile ducts, what's going to happen is that you will see that it's going to be surrounded by a closing fibrosis. By closing, I mean by constricting fibrosis. At one point in time, this constriction will be complete and the bile duct will be completely obliterated, okay? That's when the retrograde, bile will happen to the higher levels, from that level. And the retrograde flow of bile is going to destroy, first the portal tract where the biliary ducts are present, and then it will spill over into the lobules and destroy the lobules in the process, creating the cirrhosis, and we call it biliary cirrhosis because the etiology is a bile retrograde flow. All right. Now, again, when it comes to the lab parameters of this patient, you are going to be finding that it is associated with increase in alkaline phosphatase and with also gamma glutamyl transferase. That's actually where the money is. You will see, moderate to severe increase of the two, from the get-go, from the start of this process. Now, the others, the ALT, AST, maybe in the beginning, maybe they are going to be normal. Okay, that's one. At the same time, the presentation for some patients in the early stage of the disease may be left only to a single isolated increase of alkaline phosphatase. So when you ever hear that, a single elevation of alkaline phosphatase, always keep that in mind. Okay. One of the differential diagnosis of the alkaline phosphatase of the biliary epithelium origin that you should keep in mind. Now, this entity is also unique, in the sense that it is associated, similar to what you see with autoimmune diseases, with other diseases, of the same kind elsewhere in the body. So the primary sclerosing cholangitis is also associated with primary sclerosing thyroiditis, also known as Riedl's disease, also associated with a primary sclerosing mediastinitis, okay, and other lesions also in the body where you may see the same kind of presentation, a sclerosis that is simply destroying, the nearby, organ or the organs that is associated with it. Here is the characteristic lesion that we are talking about. You can see that this is the bile duct, and it is surrounded with this fibrosis that is closing in to the point that at one point in time, it will simply be completely gone, completely blocked, obliterated, destroyed, and the bile will no longer be able to flow towards the common bile duct, and rather will be flowing upward, towards other parts of the liver, causing the biliary cirrhosis that we have talked about. Here's an example of that with a trichrome stain. You can see the intense fibrosis that is associated with it. Now, the trichrome stain is not simply, staining for you the fibrous septa that creates this regenerative nodule, but also actually is surrounding this duct, showing you the surrounding lesions, the onion skin lesion surrounding this ducts everywhere pretty much, eventually destroying them in the process. Let's see, what is this? Okay, now we're going to be talking about hemochromatosis. Don't mistake hemochromatosis for hemosiderosis. Hemochromatosis is a primary genetic disease. Hemosiderosis, which really the best way to call it, is secondary hemosiderosis, even though you see some references, point to it as hemosiderosis only, but it has to be secondary. The hemosiderosis is secondary to dependency on blood transfusion. That's what you see in intractable, severe forms of anemia, such as the thalassemias. As you know, short of genetic treatment, genetic therapy, there is no treatment for thalassemia. The patient will be dependent on transfusion for the rest of his life. Those patients will eventually, they are going to be actually developing overload of iron in their bodies, But that overload of iron will be nowhere near what you find in hemochromatosis. Always genetic diseases are far more powerful, and the genetic insults that will drive the disease is far more powerful than any kind of thing that you do as a physician or as a treating a healthcare person. So in this case, you will see that there is a genetic insult. If you want to think about it, the genetic insult that you see with hemochromatosis is going to be related to a faulty sensor. So the sensor that is entrusted with absorption of iron from the GI is faulty, meaning it keeps indicating that there is low iron coming from the GI. And as a result of that, the body is actually keep absorbing iron. It does not stop. And the end result is going to be overwhelming, not just the GI and the liver, but simply everywhere in the body, with this iron that is getting absorbed continuously. So it is a systemic disease. You will see iron getting deposited everywhere in the body. It will result in multiple pathologies. And that makes actually for a nice question on any exam, you may see. So let's say that it gets deposited in the myocardium. If that happens, then it's going to result in what is known as a restrictive myocarditis. Let's say that it gets deposited in the pancreas. It will result in pancreatic inflammation, and then pancreatic fibrosis and development of type 1 of diabetes. Okay, it's going to result in development of diabetes, and it's going to result also in development of malabsorption, because the two components of the pancreas are going to be affected. If it gets deposited in the liver, it will result in liver fibrosis, and then cirrhosis and liver failure, and then it may actually go on to develop liver cancer. So it's a multiple kind of organs that are affected with this process, and that makes for a very nice case on any exam. All right. Now, let's see. All right. So a little bit about the genetics here, for this disease. And then what you're going to be finding actually in terms of the deposition in the liver. So in the liver, if you're going to do an iron stain, you're going to be able to actually grade the amount of iron that is getting deposited in the liver in patients with hemochromatosis. So you will see that there are several levels for the severity and for the amount of the iron that is getting deposited in the liver. And with each increase, there is going to be an added insult to the liver. There is going to be added damage in the form of fibrosis. Then eventually it will result in cirrhosis. And I mentioned to you that the diabetes, it's a type 1 diabetes because the Langhans, the islands of Langhans are going to be destroyed in the process. Okay, may get deposited in the joints as well, resulting in arthritis. Now, what is actually the most important test that you need to do to confirm primary hemochromatosis? You may do a lot of parameters, all of it are going to be helpful, but the most solid evidence, what you call the gold standard, is if you do a biopsy of the liver and then you measure, by sending this tissue to the chemical pathology lab, you will measure the iron that is present in this biopsy. And that's going to be counted as, per 1 gram of dry liver weight. And that's actually going to nail the diagnosis for you. This is the gold standard right here, 3,000 microgram per gram of dry liver weight. What's the treatment? Bloodletting. You take out as much blood. There are people who are dependent on blood transfusion. These patients are going to be dependent on bloodletting. Iron is very toxic to pretty much all organs when it starts to exceed normal amounts, and especially to the liver. Okay. Here's an example of that, where you see the accumulation of this iron within the liver architecture. All right, and simply, at one point in time, the normal lobular architecture will be gone, and you will start to see again the regenerative nodule that is inundated with the accumulation of the liver in it. Okay. All right, the other disease that we want to talk about is Wilson's disease. Wilson's disease is not iron, but rather actually copper accumulation. Similar, like it in terms of the end result of what it will cause, but different organs actually. So you will see it in the liver. It may actually result in, again, cirrhosis and eventually, hepatocellular carcinoma in the long run, if the patient does not, undergo chelation. But it may actually be seen also in very peculiar organs, such as the CNS. And also the eye, actually, another very odd location for the accumulation of the copper in those patients. As we have seen in the hemochromatosis, there is a genetic insult here. The genetic insult is actually in the protein carrier, in patients with Wilson's disease, the gene coding for the protein carrier that transfer the copper, to the biliary duct. And because it is faulty, there will be no transfer, and rather, the copper will start to accumulate in the liver itself. And the end result is going to be damage to the liver and also overflow of this copper to the rest of the body. All right, so the patient presenting with Wilson's disease, is going to present, as I mentioned to you, with some odd findings, including, what you call Parkinson's-like syndrome, resulting from the accumulation of the copper in critical regions in the CNS, and also in the eyes, where you see a Kaiser-Fleischer ring, around the eye, as we will see in a second. All right, so if you have a patient who's presenting to you with liver problems and it's a young patient, Wilson's disease should be on your list of differential, okay? Definitely should be on your list of differential, because it is rare for a child to be presenting actually with liver diseases. This is usually liver diseases or disease of the old, probably with the exception of hepatitis A, all right? So anything that is, coming in with a young age, you have to consider, genetic, basis for the disease, whatever disease that is, and that's a good example here with Wilson's disease. Again, there are a lot of tests that you may do. The gold standard is going to be biopsying the liver, an invasive test, but it will give you the 100%, gold diagnosis in this case. So biopsying the liver and sending the biopsy to the chemical pathology lab, where they are going to be, measuring the copper, levels for 1 gram of liver weight. So anything above 250 microgram per 1 gram of dry liver weight is going to be, diagnostic of Wilson's disease. All right, and the Parkinson's, that we have talked about is there actually in those patients: tremors, rigid dystonia, mask-like face, drooling, dysarthria. So all of this are related to Parkinson's-like symptoms, and it is associated with the position of the copper in the critical regions in the CNS, in the brain. Kaiser-Fleischer rings. There's a nice picture here that you will see, and some psychiatric also presentation, including depression and compulsive behavior. Just 1 second. I did mention to you, and the chelation therapy. All right, I wanted to actually tell you exactly where this is located. So the copper in this case is deposited in the discimate membrane of the cornea. As you can see here, this is the brown one. What's the color of copper in the ambient, in the environment that you see all around you? Are you guys with me, or did you go into comatose state? Hello? There are some answers. Brown, I agree with that. Brown, yeah, it is brown. All right, so about 1 to 3 millimeter wide for those who are interested in ophthalmology. It looks reddish green, does it? Yeah, I think slightly reddish green, probably. I mean, you can make it into any color you want, and appear at the corneal limbus. With a rare exception, they are diagnostic of inherited hepatolenticular degeneration, Wilson's disease. This is the other, name of the disease. If you recall, I told you always to beware of other names of the same diseases. Hepatolenticular degeneration, right? All right, so here actually you see the injury in the liver that resulted from the deposition of the iron, the copper. And you can see that there is what looks like, a lot of steatosis, one of the features that you see in Wilson's disease. Again, it's not diagnostic or even specific, actually. It's characteristic because, it can happen in other conditions. Someone with fatty liver presenting, with Wilson's disease or with any other disease could be presenting with this kind of presentation, the macrovesicular steatosis. There is also, this intense inflammatory infiltrate that started the bridging process. You can see that the nodule has started to form right here, actually, okay? Started to be surrounded from all sides with this bridging, necrosis, bridging inflammation eventually. Now before that, if you would like actually to see what is causing it, one of the stains that you may use is rhodanine, which is a copper stain. And if you stain that biopsy with it, it will light up with this brown color. All right, so eventually